I am Dean Eileen Sullivan-Marks, and welcome to everyone to our wonderful home here at 433 First Avenue of the Roy Myers College of Nursing. And I'm so excited today for this program. Of course, it's near and dear to my heart as a person who spent most of my career in the area of older adults. And so today we've been working very hard to pull together and be able to tell you a new story of our ongoing support of the work in aging research and nursing and health here at NYU Roy Myers College of Nursing. And I want to recognize in the audience one of the main contributors to the early work that we've been doing here for decades, Mr. Norman Volk, who formerly the Hartford Foundation, who initially started our Hartford Institute for Geriatric Nursing. And so we are going to tell you more about where we're going in the future today. I'm going to introduce to you Dr. Tara Cortez, who's our host. I'm going to read a little bio. So Tara has been recognized for her distinguished career spanning both executive leadership, nursing education, and research and practice. And it's so important to be able to bring all of that together in academics. She's made significant contributions to advance the health of people, particularly those who have limited access to care in healthcare systems. She has had a lot of funding, as we all know, through the U.S. Department of Health and Human Services, Health Resources and Services Administration, otherwise known as HRSA, as well as private foundations, and we just got an email of another one this afternoon. Congratulations from the New York Community Trust. And it's always great to have breaking news. And to implement healthcare delivery models to increase access to appropriate care for older adults, particularly in New York City and in areas where that is needed, such as the Bronx. She herself was appointed in 2013 through 2015 as American Political Science Association Congressional Health and Aging Policy Fellow, and in that role serves as a senior advisor at the Center for Medicare and Medicaid Services in the Office of Medicare and Medicaid Coordination. That office was established by the Affordable Care Act in 2010. And in this role, she has worked with multiple organizations in Washington addressing the needs of frail adults who are Medicare and Medicaid eligible. And as we know, those are the most ill and group that has functional impairment, but with attention can really turn around and have excellent health in that capacity. She is a member of the Health and Human Services Advisory Committee for Primary Care Training in Medicine and Dentistry, and is the first nurse to serve in that capacity. And she is a clinical professor and director of our Hartford Institute for Geriatric Nursing here at Myers. So welcome, Tara. Look forward to it.
Thank you so much, Eileen. It's truly a pleasure for the Hartford Institute of Geriatric Nursing to host this research symposium tonight. It's our 21st year of operation in furthering our mission to ensure that older adults achieve optimal health and quality of life. Just to give you a little background on the Institute, we further our mission in many ways. One way is through our educational arm here at Myers, where, for example, we offer geriatric experiences to students through grant activities. The Hartford Institute for Geriatric Undergraduate Scholars program builds the geriatric capacity of undergraduate students, and the development of a postmaster's certificate program in the care of frail older adults. Other colleges use our vast resources on our website also for their teaching purposes. We also further our mission through our practice arm, where we develop the practicing workforce to care for older adults, and we trial innovative models to increase access to age-appropriate care in the right place at the right time. We also have an arm in Washington and in Albany, where we influence policy by educating legislators and utilizing appropriate appointed and elected offices to leverage and expand the work that we do. Since aging is a global issue, our reputation as an expert resource in the field of geriatrics has led us to develop a global arm. We have had consulting engagements in Saudi Arabia, and Saudi scholars have come here. We had 3 of them here last summer to learn from us. We've also consulted in Ireland, Shanghai, Hong Kong. We're going to Singapore in May, and our website is accessed by more than 50 countries worldwide. And tonight, we are highlighting our research arm, which serves to further the development of the science in the field of gerontology. In tonight's program, we actually officially introduce Dr. Bei Wu as the Director of Research for the Hartford Institute. Dr. Wu will spearhead the continued growth of gerontological research at NYU Myers to provide evidence for the Institute's evolving programs and contribute to the field in line with the Institute's mission, which is to ensure older adults achieve optimum health and quality of life. And we're going to begin tonight's program with, we have 2 panels. And we're going to begin with our first panel, and I'm going to introduce the first panel to you, and then I will get back up and introduce the second panel to you. Please note in your programs you have an index card. That index card is to write questions on. And if you need another index card, raise your hand, and then we keep all around on the sides to give you another index card. But put 1 question on each index card and submit it. We will collect them during the course of the evening's activities. Our first panel tonight is entitled "The Role of Science in Advancing the Care of Persons with Dementia and Their Caregivers." Our moderator is going to be Dr. Chris Kovner. Dr. Kovner is a highly respected and widely published nurse educator and researcher at New York University. Her primary appointment is with Rory Myers College of Nursing, where she is the Mattie Mezzi Professor of Geriatric Nursing and a Senior Faculty Associate at the Hartford Institute for Geriatric Nursing. She studies the nursing workforce in terms of having an adequate supply of qualified nurses to care for older adults and how the aging of nurses and workforce impacts the supply and demand for nurses. One of our panelists, Dr. Bei Wu, would you come forward, please? Dr. Wu's research interest is to address health disparities among older adults and improve the care of frail older adults in the U.S. and globally. As principal investigator, she has led, and my notes here say, a significant number of funded projects. Dr. Wu is a very, very well-known and well-funded gerontologist who came to us a year and a half ago, and we're delighted to have her at NYU Myers. I'm particularly delighted to have her at the Hartford Institute. She has had significant number of funded projects and has more than 360 publications that cover a variety of topics related to aging and health, such as oral health, long-term care, dementia, and caregiving. Dr. Ab Brody. Dr. Ab Brody is an associate professor and the associate director of the Hartford Institute for Geriatric Nursing. Dr. Brody has a large portfolio of extramurally funded research focused on developing and evaluating models of care to improve the quality of life of seriously ill and older adults in the community. Dr. Brody has he's had several fellowships. One was the Robert Wood Johnson Nurse Scholar Fellowship, which he has just completed, and I feel very blessed to have him as the Associate Director of the Institute. So I will turn it over now to this panel.
Thank you, Tara. I'm going to ask you some questions to kind of get everything rolling and see if we also have questions from the audience. From reading your CV and knowing you, you work on both palliative care and also dementia. I have some questions about palliative care, maybe at a basic level, like what is it? But I think there's some confusion about whether it's just for dying people that we do it. And the other thing that's come to mind to me with the opioid crisis, are we worried that older adults like my mother will become addicted to opioids?
We're starting off with the easy questions this evening. So I think one of the biggest misperceptions is that palliative care is only for people with cancer at the end of their life, when they are having their 8th line of chemotherapy and about to pass away, and that's the time that we provide them with lots of opioids to palliate their suffering in that last moment. And that is about as far from the truth as we can get, but unfortunately there still are some myths that present themselves. I'd say the way that we're presenting it now is that palliative care is around helping adults and children, so it does go to life spectrum, with serious illness from the moment they are diagnosed all the way past when it's the end of their life into helping family members who are bereaved following a patient or loved one's death. And so it really is a continuum, and as the amount of curative care lessens because of the advancing of the disease, the amount of symptom support generally needs to increase. And so that's the trajectory of palliative care. As it relates to the opioid crisis, I think there's also a lot of misperceptions and sensationalization, and several of the recent books that have come out have tried to hinge the entire opioid crisis on a very small study that was done in chronic pain patients in 1980 that very much, if anyone knows anything in academia, one study on, I think it was 56 subjects in 1980 does not lead to an opioid crisis. And so really where the issues with the opioid crisis lie are with patients who have access to pills largely through pill mills, or who have an acute injury. And instead of being prescribed maybe 3 days of medication, are prescribed 30. And so this is why we're starting to see regulations and laws that are more related to not allowing emergency department providers to prescribe beyond 5 days worth of medications. For patients who have chronic pain due to serious illness, addiction is a much less substantial issue.
Thank you. That was
Chris,
useful.
could we check Ab's mic because we want to record this session?
Ab's correct. Neither of you are mic. You have to unmute your mics.
Okay, I've turned this to the opposite of mute.
Patrick, are they fine? I'm sorry to interrupt. We're just recording this stuff.
I also have a loud voice, so.
Yeah, but we want to make sure.
It's recorded. That's
It's being
the
recorded in video. We want to make sure we catch everything you're saying.
I was unmuted.
Sorry about this.
Luckily, this is not live TV.
All right.
Ab, so I also know that you do work on dementia, and you have some research projects now going on. Can you give us a little bit, and do you have any early findings that you can share with us?
So one of the issues within palliative care is that it has largely not focused in geriatric populations and mostly within cancer. And it's now not that cancer is not a disease of aging, but it had been primarily oncologic focused since its inception, and that's now starting to change. One of the areas that has had very limited focus in terms of the palliative care world is dementia. Even as long as 3 years or 4 years ago, one of the biggest discussions that was had was around which antipsychotic is the right antipsychotic to be giving to persons who are living with dementia who are having behavioral disturbances. And we know those medications, and this was after a black box warning came out that showed that those actually harm patients substantially. That was still our discussion, and only now is that beginning to transition. And so a lot of my work focuses on how we can help providers within the community at all levels, from physicians in primary care practices to home health and hospice clinicians of multiple different disciplines, in how to provide effective palliative care to persons living with dementia and their caregiver. And the key is that second part, because the caregiver is the one that bears the brunt of having to help people live with this illness, and they're also the ones that are stressed, burnt out, and develop health problems themselves. And so the work that I do largely focuses on helping clinicians to understand what the practices are out there, mainly without pharmacologic means, so mainly with non-pharmacologic interventions to modify behaviors in order to improve the quality of life of the person living with dementia as well as the caregiver. And shockingly, a lot of it is about understanding who that patient is, who that person is, and their needs and capabilities and helping them to maximize them.
Can you give us a little tidbit of any early findings? You're doing something in home care.
Yeah,
Do
so I
you have
have
any early findings?
I have one study that's been completed now that showed that when we provide a multimodal intervention for home health nurses, physical and occupational therapists, that their level of knowledge, confidence, and attitudes increases about 25 to 30% from a abysmally low baseline in how to manage symptoms of people living with dementia. And then on top of it, it helps to increase the identification and management of pain and reduce the use of antipsychotics. And so one of the major causes of antipsychotic use is because patients become, the probably incorrect term is agitated. The correct term is in pain and not having their pain managed. And so by managing their pain alone and assessing that, we can reduce these other behaviors that are hard for caregivers to manage.
Sounds fascinating.
So,
You know, I'm a 96-year-old mother, and so as opposed to having they and everybody else in the College of Nursing knows I have a particular great interest in these topics, and it's wonderful that you're doing that work. And I probably should have a one-on-one with you so that you can help me with whatever the skills are that you're teaching home health nurses.
And it's expanding as well. So we're also performing a trial now in one of our local hospices, MJHS, that's seeing if these similar principles, but with a different interdisciplinary team, will work in the same manner.
Great. Speaking of my mother, so my mother's 96. She's in good health, and she's in assisted living, and she had some doctor's appointment in dermatology. I mean, nothing particularly serious. And I realized, because I'm kind of in charge of her medical care, that she hasn't been to the dentist in about, more than a year. She has good teeth and no problem. She can eat everything, chew everything. And must she go to the dentist? Dave's been doing a lot of work on oral health.
Right. So, certainly that would be great if she does that, because oral health is an essential element of healthy aging. There's increasing evidence suggests that oral health is strongly associated with poor oral health, actually strongly associated with cognitive impairment, functional impairment, chronic diseases such as diabetes and cardiovascular disease. So our team has contributed significantly to generate new knowledge into this field. So one paper that we published several months ago looking at actually national longitudinal survey, and found that tooth loss actually can be maybe an early indicator for accelerated aging. So certainly that if we think about this, then keep good oral hygiene and the regular preventative care, dental care is certainly the two most important ways that can maintain a good oral health. So certainly in your mother's case, the genetics certainly plays a role, so we don't want to underestimate that. So it's lucky that she has that, and it certainly helps in a way. But on the other hand, it's interesting, one manuscript that our team is writing right this moment. Actually, this morning I was looking at some data that found that looking at the national longitudinal data, we found that actually U.S.-born Caucasians, older adults in your mother's age, 95 years old, we found actually the likelihood of annual dental visit actually is 77%. So when you look at the
So
stuff,
not so bad that she hasn't been in a year, dealing with the
77% chances of actually going to have a annual dental visit. But certainly it's interesting to look at the 50 years to 100 years. This is kind of like that kind of shape. To reach actual point is 75 years old. Then actually they have the highest kind of rate of annual dental visit. Then they start kind of declining. So that's you measure into that kind of declining kind of slope in a way. So, but that's but also we found even from my previous work that having somebody that social support plays an important, very important role in dental care visit. So having somebody that with your mother to accompany your mother to a dentist actually can play a very important role to that. So you certainly has a lot on your shoulder.
It's on my little dad with the dentist, because I asked my mother, of course, what was the name of your dentist? She couldn't remember. I had to go through her book to find the dentist, but it's on my list. And so you do a lot of international work. Can you tell us a little bit about some of the international research you're doing?
Yeah, I can
anything on oral health, or where's that focused?
Yeah, I can probably spend 1 or 2 hours to talk about this,
Okay.
but certainly I'm going to shorten this in probably 5 minutes.
Okay.
So actually, this population aging is a worldwide phenomenon. And the aging, when we facing aging challenges is absolutely unprecedented in human history, because we actually have not facing this kind of issues in entire human history. Now we're facing this. So it's a kind of a worldwide phenomenon. So that's why I'm a strong believer that so many countries are facing kind of similar challenges. That's why we really need to learn from each other. We have a lot to learn. In the U.S., we have a lot to learn from many other countries, European countries, Japan, and certainly China, and India. We just published the paper on Indian population. It's quite interesting. We look at cognition, migration, and migrations, early migration impact on later kind of cognition in Indian population. That actually was using large national representative data. So my work in China, not only in China, and currently in Singapore and Norway. So basically in 3 kind of areas. One is that looking at long-term care, working with my colleagues, kind of develop long-term care policies in China, how to kind of think about how we can provide this kind of, develop these kind of policies is the one thing. And the second kind of area is using a secondary data set. We have a fabulous teams of individuals that work in many different areas related to aging. Look at particularly in terms of cognitive impairment, look at dementia, and caregiving, and resilience of aging. So this is the second piece in terms of secondary data analysis. Then the third piece is the primary data collection. Look at, we have a piece, we have an intervention project here in the United States, which is at Duke. I was at Duke at that point when I launched this project. The comparison study in the United States, in Singapore. Look at how actually working with family members, how we can actually improve oral health for persons with cognitive impairment, mild dementia as well as mild cognitive impairment. So this population, and we have actually very fascinating kind of results coming out. That's actually a part of the results, preliminary results we put in our U01 grant. So we'll cross our fingers that this U01 will come very soon.
Not everybody knows what a U
Oh,
grant is.
It's a kind of similar like our U01 project. It's a 5-year multi-site kind of project. We got a pretty good score, and NIH suggests that they will recommend for funding. But now NIH does not have a budget yet, so we're kind of just sit tight and wait. So this kind of look at the intervention project, this kind of international work certainly help to provide preliminary results. Then also, we just actually recently launched the Centenarian Study, working with faculty from actually Sweden, Hong Kong, and China to launch this Centenarian Study in Nanjing. We actually are going to identify every single centenarian in Nanjing, this city, that do a primary data collection, use a mixed methods approach to identify.
Every person who's
Yes, it's 300 some individuals in Nanjing. We're going to approach them. Whether we can get the full sample, we don't know at this point. Is actually each individual has their own story. When I actually went to the field and just interviewed these two individuals, already this is such a kind of rich experience that can certainly have a new knowledge. How these individuals that cope and adapt with adverse life events during this aging process is a fascinating story. We have lots of fascinating stories that can
And then
share.
how are you going to combine all those stories?
Well, this is that's why it's you look at the individual's aging process as well as actually at the population level kind of aging process. We can certainly think about using quantitative and qualitative research methods to do that. So to be continued. So this is something it's just a lot, so I don't want to kind of go on and on.
No, it's fascinating, and I don't know how you keep track of all of it.
Yeah, I have an Excel sheet.
Oh, you so, in thinking about the future, because I'm getting older, what are the research issues that we really need to focus on? If there was a PhD student who's very interested in aging, was one of your students, what might you suggest to them? Or if there was a policy committee at the NIH saying, let's prioritize the research issues, what would some of those be?
So I think there's two issues to look at, well, of many. One of those issues is we've learned a lot of stuff in the last 50 years. We have not learned how to actually get those things we've learned into practice effectively and efficiently. And so this is across fields, but particularly important in geriatrics and palliative care. There's about 7,500 geriatricians, about 1,500 geriatric specialists, nurse practitioners, around 7,000 palliative care physicians nationwide, and a similar number of palliative care nurses. And so when you look at the population, there is no possible way that the specialists are going to be able to handle all of the patients who are older and aging gracefully in some cases and not in others. And so we need to learn how to take all of this geriatrics and palliative care knowledge and really weaponize it so that we can get it out into the communities, into the clinicians and non-clinician areas so that they can use it and learn what we know without the additional thousands of hours of training, which we know we don't have the capacity to do. And that's one of the things that the Institute has done for the last 20 years. It's why our Try This series and some of the other things that we do have made a name for it nationwide, starting with Maddie, Nessie, and Terry 20 years ago. And it's a key part of our future. And I'd say the other thing is learning from those other countries about social spending versus medical spending. And learning how to effectively switch some of the way too much medical dollars that we currently spend into more social programs for preventative and supportive care rather than for over-aggressive medicalized care that doesn't work to improve the quality of life of our older adults.
That's a tough one. The second one.
Right. So certainly this is a global. Oh, sorry.
No, go ahead. So what do you think some of the issues we have to focus on are?
Well, certainly that from a global perspective, we need to kind of learn from other countries. Then you kind of broaden our view to tackle this aging process. I think actually it's not particularly, there's so many kind of issues that we need to tackle. Is every single one of us that think about kind of research projects or think your project is very important in your way. Prioritize. I don't want to kind of impose my research questions, kind of area of interest into this, and certainly like think about dementia is so important, think about dementia caregiving is so important. But I really want to kind of, we're sitting in this School of College of Nursing, to think about is how we actually, now it's like a multidisciplinary research, it's like a buzzword. Everybody wants to use this kind of. But it's really to think about, it's a team science. How we actually, we are dealing with individuals. Individuals, we're dealing with human beings. There are a lot of actually multiple layers of issues that you need to kind of focus on. So it's really think about, for example, when we design this kind of interventions, how to think about, it's not just one particular issue they're dealing with. It's not like, because of the memory issues, etc. It's really think about from environment perspective, think from kind of family supportive kind of environment perspective, as well as like from behavior, from medical kind of research. It's a team science that we need to build. So that's why I think that from our each of the disciplines, that we really need to kind of break down this kind of boundary of discipline and work, what is the kind of issues that you're targeting to, so we can actually convene the team from many disciplines to tackle that particular issue. So that's actually, we can really try to advance the field forward. So that's what I think is a team science kind of approach.
And you have been very successful at doing that.
Correct.
How have you been able to be successful doing that? Getting teams to work together?
Right. Certainly, that sometimes we speak different languages. Certainly, but we need to actually think about how we kind of sit together and brainstorm ideas, and we can actually branch, and everybody bring their own perspective into the table. So we need to be, well, of course, you need to have somebody in charge, right, as the PI, otherwise there's nothing will move forward. So, but think about how actually to rely on each individual's strengths to develop a project.
Sometimes what happens in research, as you know, I'm very involved with our Clinical Translational Science Institute. There become issues about who's going to be the PI.
Well,
and that's a big issue in team science, and how do you handle that?
Well, like who is in charge, of course, that we always have that, like who is in charge. Then who kind of co-investigators bring into the table. Right. Of course, then as the PI, you do the most of work. Basically, when we're writing grants, the bottom line is like, who's writing this, right? It's not like, like you can write a piece and I can write, but who actually does majority of the work? That's what I think it's really need to be clear on that. So,
and I think some of the other problem is really that academia is not set up to allow for team science to occur, because we put so much emphasis on, are you the principal investigator? Are you the first author? Are you the senior author? And so what ends up happening, and there's starting to be some subtle shifts in how this is viewed, but not the leaps we need to take, is how do we ensure that the people who are doing the research have the credit that they need for advancement within their institution, but that the institution can take effect and understand that there is no one-person science anymore. There used to be one-person science, but if you have one-person science, your science is generally going to fail now, because you're not going to take into enough perspectives. So right now I'm on a $12 million grant from the Patient-Centered Outcomes Research Institute that is testing two arms: early palliative care in the community with palliative care teams, or nurse-led telephonic palliative care. I'm the only nurse investigator on that team. They could not have a nurse investigator on a telephonic nurse-led arm, but I don't need to be the principal investigator. In fact, I don't want to be. Of this study, which is an incredibly important study.
Well, what are the other disciplines involved?
We have emergency room physicians, we have geriatricians, palliative care physicians, there are social workers involved. Some of our telephonic nurses are actually social workers and nurses. And so it's the team coming together with both mid-career, senior, and early coming together to make greater whole than the sum of our individual parts. And so when you leave ego at the door and you just don't worry about the who's going to get what, and you're part of a team to advance a mission, I think that sometimes people are able to step back and let the ego part go. But it only happens if the institutions allow it to happen.
Well, and I do think at NYU Myers we're very aware of that, and we do take that, think about that, and do reward and try to motivate people to do team-based research because we think it's very important. We have a question from the group. Can you specify some of the non-pharmacologic interventions used in dementia populations, ones that your research has shown work or that you're testing?
Sure. So there are many, many non-pharmacologic interventions. I think two of the simplest ones that we tend to overlook are exercise. And so I don't know about you, but when I sit in a bed all day, I get really cranky towards the end of the day. Or if I'm just in my office chair working on my computer on a manuscript, I'm not really the most pleasant person to be around by the end of the day. That doesn't just change because you now have dementia. And so exercise, we found in this population, helps with all of the behaviors that cause the most concerns amongst family members. Another one that we tend to overlook, which is very simple, is active music therapy. And so it has to be tailored for the individual, so you can't play top 40 if they like big band, for instance, music, but you tailor it for the individual. It's a prescription. It's an hour a day. If you can, you want to have them dance with you or walk to the music with you or even tap their foot, because it's the active part of it. That helps. Other things are reminiscence therapy, so helping people to remember about the things that they can remember, even if they can't remember what today is or who you are anymore. And so there's a lot of these interventions. They're very simple, but they're time-consuming, and they're not just a prescription and a pill to pop. And so that's where the problem lies is, as clinicians, we tend to skew towards the easy fix, which is the pill, but they don't work in this population.
Right. Currently, we don't have a magic kind of pill to do that, right?
You gonna get one?
So
Anybody working on that?
no, actually not in the immediate future.
And we're not going to at all, because dementia is many different diseases. And so we even used to think that we knew what the pathophysiology was behind Alzheimer's. We now know that we don't. We used to think it was these plaques and fibers. We now don't think those have the biggest effect, because when we targeted drugs at them, they didn't actually change anything. And so we're still so long off. The one thing we are seeing is, as cardiovascular care is being better provided, there are fewer patients who are developing dementia, because a large proportion of dementia is vascular dementia. And I don't think we actually knew that before. And so vascular health is both a proxy that can be part of Alzheimer's, but also part of vascular and mixed dementia. And as we get better at cardiovascular preventative care, we're reducing the absolute number of cases per 1,000 people.
Actually, you simply look at the trend. There's a decreasing actual prevalence rate. The prevalence rate of dementia has decreased in the United States. Well,
It's making that noise. Oh, you muted her.
Well, it's mainly actually is due to the better kind of prevention of cardiovascular diseases, and also simply more and more people adapted to this kind of healthy aging, kind of healthy lifestyle. Anyway, it's a physical activity that certainly is the most promising way to do it, and then healthy diet and mental activity, etc. These are
great idea, exercise.
Mm-hmm.
My mother.
Right.
How do I get her to exercise? I say, oh, Mom, you should take a walk. They have an exercise class. Why don't you go to the exercise class?
Yeah, you can't make people do what they're not going to do.
Right.
So I think if you didn't exercise before, you're not going to all of a sudden magically exercise as you're losing your other faculties. However, exercise can mean a lot of different things. It can mean vacuuming, for instance. So if she always used to vacuum, now you have a repetitive activity that you can do that actually does get the heart rate up. You just have to do it for 30 minutes a day, at least 3 times a week as a regimen. So there are ways that you can be creative about exercise without it being a walk around the track, a trip to the gym, etc.
Right. So this is actually really a kind of interesting point to think about that aging, healthy aging is not really we're talking about stuff from older adults. It is a life course perspective to think about aging stuff from the inception. So how we actually, what we do as a gerontologist, so we not just think about this, we're dealing with just the aging population. We really need to think about how we educate our children. How do we educate our adult population? Start actually adopt this healthy lifestyle. So that's why when you think about when the future generation of older adults, when they get older, they are already adapted this kind of healthy lifestyle. So that certainly will decrease healthcare dollars. Prevention, start from young. Prevention, that's what we need to do. Think about all these perspectives. This is right. It's a cumulative effect in a way.
Chris, you have got one more question.
One more question. Okay. Any DNA studies of older versus younger aging besides, I can't read this word, Telomer? Telomeres?
Yeah,
the question is, have there been DNA studies? I guess DNA studies maybe about why it is that some people develop dementia, why it is that some people respond better to some activities than other activities. What do we know about the phenotypes here?
So one of the largest studies that the National Institutes of Aging has ever undertaken is going on now. There is an area in, I believe, Brazil, where they have one of the largest populations of early onset Alzheimer's patients in the world. And so they're actually going through and doing really expansive genetic analyses there to understand what those who are part of these families that makes them either early onset Alzheimer's or not. There are literally thousands of other studies ongoing right now on different aspects of aging and healthy aging and what makes a 96-year-old able to live to be a 96-year-old and having their only problem be having a memory disorder, where they are pulling those. We are not there yet with that data, but there are tons of studies underway.
We need you to hurry up.
Well, certainly we actually, in the scientific field, we know more and more about the disease per se, in terms of causes, but in terms of treatment, it's still a long way to go. So.
Well, thank you. This was fascinating. As always, I love talking to you, both of you.
Thank you.
That was wonderful. Thank you to our panelists.
Columbia, thank you.
Actually, that's a Pam actually wrote an article from New York Times, reported this. It's a family actually started from 20 years old. Yep.
Our next panel is entering the center of the front of the room. This panel will talk about reducing chronic disease disparities in vulnerable older adults. And we're delighted to have with us as our moderator, Dr. Vicki Dixon. Dr. Dixon is recognized as an international expert in qualitative research techniques and mixed methods research, and has conducted training in interdisciplinary teams locally, nationally, and internationally. Her research program focuses on investigating the biobehavioral influences on self-care in patients with cardiovascular disease and evaluating the effectiveness of self-care interventions on health outcomes. Her work has led to an improved understanding of the sociocultural influences of self-care among vulnerable populations, including older workers, women, and ethnic minority groups, and the development of innovative theory-based interventions. That's Dr. Dixon on the extreme right. Dr. Billy Caceres is in the middle. Dr. Caceres is a recent graduated in May from the PhD program here at NYU, Roy Myers College, and he was a very, very active participant as well in the Hartford Institute for Geriatric Nursing. He's presently a postdoc research fellow at Columbia University School of Nursing. Dr. Caceres' research focuses on the impact of stress on cardiovascular disease risk and management across the lifespan, with an emphasis on vulnerable populations. And finally, on the extreme left up here, Dr. Tina Sadarangan is an assistant professor, faculty fellow, who was also a graduate of the NYU Roy Myers College of Nursing PhD program, and was very active also with the Hartford Institute for Geriatric Nursing during her time of study here. Her program of research focuses on improving health access and chronic disease outcomes among aging immigrants through community-based programs such as adult day health centers. She was previously a recipient of the Patricia Archbold Scholar Award by the National Hartford Centers of Gerontological Nursing Excellence, and is currently supported by the Provost postdoctoral 2-year fellowship program. We look forward to your talk.
Wonderful. Thank you, Tara. Well, this is really a particular honor for me to moderate this panel because I've had the pleasure and the joy to see these two new scientists emerge from their predoctoral days to now in their postdoctoral days. So I'm delighted to join you, Dr. Sadaragani and Dr. Caceres, this afternoon. As new investigators, you're both examining very important but vulnerable populations with chronic illness with the focus of understanding those multifactorial influences across one's life course that may contribute to their health problems or in some case help in the resilience that leads them to successful aging. Dr. Sadaragani, your work is focused on immigrant populations who are growing in numbers, very important individuals, older adults who immigrate to the U.S. in later years, and your focus is on that community access and health care. With Dr. Caceres, your work is focused on the impact of stress in cardiovascular disease, my area of research, so I'm very interested in your work always, and the management across the lifespan with a particular emphasis on vulnerable populations. And in your dissertation work, you focused on gay, bisexual, and lesbian adults, populations that we as cardiovascular researchers have often ignored. So I'm really interested to start off our discussion to learn more about how you've each approached this important work. And I'm looking here, well, let's start with you, Tina.
My lucky day. Well, thank you again so much for having me here. And as you alluded to, Dr. Dixon, the population of older immigrants is really growing, and it's not a population we often think about. But to give you all some perspective, the population of older immigrants, so foreign-born people over the age of 65, grew 70% between 1990 and 2010. And that is really a reflection of the broader racial and ethnic diversity that we're seeing in the overall aging population. So as we think about it, immigrants really, as most of us know, add so much to the fabric of this country, bringing with them their perspectives and values. But the thing with older immigrants is that they are among some of the most socially isolated and lonely and forgotten people in the country, and we don't really think about them. So when I've approached this work, that we in the research world have put them really into two categories. And so one category is people who have come to this country as children and young professionals, and they've had opportunities, whether it be through work or through school, to really assimilate and learn about American culture and really build a life here. My work has historically focused on a slightly more vulnerable subset, and those are the people who come in their 50s and 60s and 70s, having aged and grown somewhere entirely different, and then come here at a very precarious point in their life course. And so the thing that we have to think about with them is really the context under which they come here. And so many of these older immigrants are being invited here by their adult children, and usually their adult children are working in some capacity, and these individuals are coming here to help perhaps take care of grandchildren, not always, but in many cases, they come here under the premises of family reunification, which is really the cornerstone of our immigration policy. And so the issue is that because they don't work or they don't go to school, they have small social networks, they have limited income, they have limited access to transportation, many of them don't drive, and the biggest issue really is that many of them don't speak English. And so this is become, all of these things sort of aggregate to really cause problems. The area that I've focused on in my dissertation work has also been their lack of access to public assistance benefits. And so when these individuals come, they will rarely have the work, they don't have the work history required for Medicare. And then Medicaid, which is the program for indigent individuals, there's in 70% of states a 5-year waiting period. So you have to be here as a lawful permanent resident for at least 5 years before you can have access to that benefit. So what ends up happening is that a lot of these individuals are coming at a time when hypertension starts to creep up, diabetes, all this sort of silent illnesses that you all work on. But then they go undetected because these individuals don't have insurance. They can't drive themselves to the doctor. They can't advocate for themselves at the doctor. They can't pay for a physician or a provider visit. And so this is really what my work has centered around, in looking at all the different sort of social factors that contribute to the health and welfare of these older immigrants.
And they're also thrown into new environments, new cultural, perhaps lack of cultural foods, different social supports, perhaps, that I'm sure confound that work.
I should also add that they quickly pick up, while they retain some of their cultural values, they also quickly pick up on our sedentary lifestyle and all the fun Western contributions to health.
So have you tackled in your work any of the issues that the prior panel brought up around exercise or maintaining physical activity in older adults?
It's interesting. Within my dissertation work, where I focus predominantly on health insurance as a variable because I was really interested in the contribution of that variable, I did control for exercise and diet. And, you know, it was interesting. Many of them, again, the data was based on the National Health and Nutrition Examination Survey. And so it's not like they had a pedometer, so we couldn't actually concretely determine their physical activity. But in terms of the amount of minutes they logged with respect to physical activity, they actually do better than our native-born adults in terms of physical activity. But when I sort of did a sub-analysis, I found that, pertaining to my work, that not having health insurance actually doubled their risk of being at high risk for cardiovascular disease. So for them, social determinants are really important,
social determinants,
especially if they've been here for less time.
Really?
Yeah, I think the theme of Tina's work and my work is really about social determinants of health. And really, I came to nursing after studying social inequity as a political science major at NYU. And so I think that's kind of the lens through which I view healthcare and the work that we do. So for me, my interest really lies in the impact of stress. And stress means different things to different people, but it's the impact of stress on people's health and really how stress becomes embedded biologically to actually impact outcomes. So it's much more of a mechanistic viewpoint, but still keeping in mind the policies and social situations, social factors that actually created those problems in people. So I think earlier Dr. Brody had talked about the advances we've had in cardiovascular disease, and yet despite all these advances in cardiovascular disease, despite advances in social movements like the LGBT rights movement and civil rights movement, we still see huge disparities in cardiovascular care, in particular in this country. So one of the things that I really became interested in my pre-doc was LGBT disparities, a topic that I had maybe received a little sprinkle of throughout my education here at NYU, but I really kind of delved deep into that topic as a pre-doctoral fellow here. And what makes this population unique, particularly as they age, is that they might have experienced discrimination, marginalization, and really stigma for a really long 70, 80 years before they even decide to come out or even feel safe to come out. And that has implications for people's overall well-being, but also their physical health. And one of the things in particular that I really look at in terms of policies is the policies that we have in our country that either impair or promote the health of this population of LGBT people. And we still have 29 states in which you can be legally discriminated against for being LGBT in healthcare facilities. We have 19 states in which it is not illegal to commit a hate crime against an LGBT person. There's actually no legal recourse in that sense. So thinking about how these policies might impact people's health, even if I would venture to guess that most LGBT people probably don't even know if their state has or doesn't have these policies, but it's the general environment and aura and social status that these individuals have. And in many ways, when we talk about immigrants or other groups, it's really about this kind of, it would be bold to say, but it's this kind of second-class citizen status, whether or not you're a citizen or not. But it's feeling like your position is lower compared to other people. And there's been dozens, hundreds of studies studying this in animals and just simply looking at monkeys or apes and looking at social position and what happens. So what happens to their immune function, their cardiovascular function, and how actually flipping those dynamics can actually improve someone's health in the short term and the long term. So really my dissertation was focused on stress and cardiovascular disease risk in lesbian, gay, and bisexual individuals, really looking at young and middle-aged individuals. And what I thought that I would find, what I posited, was that yes, they would have higher rates of smoking and alcohol use and stress and obesity in the lesbian and bisexual women, which has been shown in the literature. And I published a systematic review on this topic last year, so I kind of knew that. But the interesting thing for me was that I thought, okay, age is one of the biggest risk factors for heart disease. So I would have thought that as they age, that they would look more similar, despite some of the risk factors they engaged in earlier in life. And what we actually found was that as they age, particularly lesbian and bisexual women, had at midlife were much more likely to be obese, much more likely to have hyperglycemia compared to women of the same age group. So I think that that really creates a special, it kind of sparked this interest in me, one, in women's health, and two, really looking at midlife as a crucial period in the development of cardiovascular disease. And that work is what I'm continuing to do now in my postdoctoral fellowship at Columbia, which in many ways my work has expanded and in some ways it's narrowed. So and by that I mean that I'm now looking at other populations like Latinos and African Americans, looking at similar issues. But in some ways I've decided to focus really on the impact of trauma and specifically interpersonal violence on people's health and how that impacts health, and really looking at it through a life course perspective, looking at experiences of violence throughout the life course and how that really has implications for people's health in midlife and beyond. So that's kind of an exciting new area that I'm starting to get into, and I think the crux of it really has to do with social position and social inequity.
So let's talk a little bit more about these social determinants of health and how you're continuing, it sounds like, with that theme even in your postdoctoral work. There's some other commonalities perhaps in your two programs of research?
Yeah, I mean, I would certainly say, Dr. Dixon, a main commonality between my and Billy's work, and always has been since we've been in school together, has been this emphasis on social determinants of health, on the psychosocial components of health. And I think that's really become clear about how context, historical context, political context, structural context, give rise to the experiences and the health outcomes of the populations that we work with. But one interesting thing, as we both began to talk and listening to what Dr. Wu was saying earlier, is that both Billy and I really look at things from a life course perspective. And, that's to say that even though we focus on older adults, we're not just looking at them in old age. We're looking at sort of the points in their life that perhaps in Billy's case, the aggregate effects of trauma, discrimination. And in my case, this precarious point in the life course, what does it mean to move when you're 60 or 70 versus when you're 10 or 5? And how do these different things sort of affect your health in the long run? So not only is it just the psychosocial aspect of health, but it's also this idea of the life course and how that contributes to health.
I agree with what Tina had to say about that. I also think that it's this idea of being an other and feeling like an other in a sense, and that I've had recently people tell me, I think I met with a statistician a few weeks ago, and they said to me, like, that it's so hard to actually ask people about their childhood trauma because it's all about recall, and what if they don't recall it correctly? And I turned to him and I said, it doesn't really matter whether or not they actually experience a trauma. It is the fact that they believe they experience a trauma, and that in itself has an impact on their health. And I think that that idea of experiencing feeling like an other, or feeling like, or knowing that you don't have access to the same resources, that in itself speaks volumes. You don't really need people to tell you, like, you're different than these other people. It's a sense that people feel, and I think everybody in this room has felt like an other at one point or another in a room in their lives. And think about having that be, but we can actually move in and out of situations where I'm not an other. I'm in situations where I am part of the majority. And I think when you think about it in these marginalized groups, I'm just going to say marginalized or vulnerable groups, that otherness doesn't necessarily go away. And I think, and if we think about it, older immigrants coming to a country, that's like the definition of being an other, right? When you leave the household, you are an other. When you think of being, somebody recently said to me, yeah, but some of these LGBT issues aren't really applicable to like younger populations because there's so many out people. But there are children all over this country, teenagers, who are struggling with their sexuality or their gender identity, who are thinking about committing suicide or are engaging in risk behaviors that in the long term are going to have an impact on their cardiovascular health, their emotional well-being throughout their lives. So I think that it's really taking a step back and thinking about, yes, I'm not a woman, but I can see how being a woman carries within itself certain risk factors and vulnerabilities that impact your health. So I think that might be one of the commonalities.
So as I reviewed your CVs in preparation for this panel, I was very impressed and of all the great work that you've done here. Again, on very different, unique populations. So what do you feel now as you're sitting as postdocs, fully graduated? What has been really the most important, or several of the most important things to your program of research?
So I think in many ways I see myself as having grown up in some ways in the Hartford Institute, in many ways actually, because I actually worked at the Hartford Institute when I was a politics major and as an undergraduate student at NYU, and I wasn't even thinking of becoming a nurse. And really, I think I was going through, and Sherry Greenberg knows these well because I knew her name years ago before I ever met her, all the Try This series, which people are familiar with, and just going through the Try This. And I think one of my jobs was organizing them in this file cabinet, and I would read about these things like dementia and all the like falls and older adults, and I knew nothing about these issues. And that really kind of made geriatrics a priority for me as a clinician moving forward. And then I worked here again as an undergraduate student, I was a nursing student, and really have had a relationship with the Hartford Institute the entire time that I've been at NYU and now beyond, now that I've left NYU. And I think that in terms of having the resources and the expertise in aging, chronic disease, health disparities, that was really helpful for me in my development. But also I was fortunate enough to be a pre-doctoral scholar at the Clinical and Translational Science Institute, and most of that work really focused not only on translational research, but also how do we work with other disciplines and in teams to really bring about research that is translational and that has clinical implications. And I think that that has always stayed with me in terms of feeling like the work that I'm doing has to have a clinical component and actually be able to improve the care that people receive in some sort of way. So I think in many ways that the Hartford Institute has kind of been part of my development the entire time that I've been here.
I would have to agree with Billy. I also did my BSN here as a second degree with Billy. So, the Hartford Institute has always been part of my education, and I've always had the support of the deans and the faculty to pursue a real research track in the health of older adults. This has been an interest of mine for as long as I can remember. And so I really think Hartford and Myers in general just has so many resources for individuals who are truly dedicated to improving the welfare of older people. And in that regard, not only they allow us here, just the sheer expertise of the faculty allows us to really approach problems holistically. So in my case, I have been lucky to be surrounded by faculty with expertise in anthropology, sociology, policy, and also those of you who do cardiovascular disease. It's just really a holistic approach to the treatment and management of chronic disease in the older adult, and that's been huge for me. And this idea that within Hartford, especially Dr. Cortez's work, it's not just about people who are coming up with problems. There's actually people here who are really coming up with innovative, creative solutions about how to address them. And that's something I'm really proud to be part of. Especially my current program of research focuses on adult day health services and how we can adapt those services to meet the needs of this population of older immigrants and limited English proficient individuals. So I feel very supported in that regard. I should also add that outside the College of Nursing, within just the broader NYU community, there is so much interdisciplinary support. For me personally, the Center for the Study of Asian American Health and the Department of Population Health has been instrumental in helping me understand this population and gaining content expertise, as well as skills in community-based participatory research. And I say that not only because Simona is here, but really because they've been so helpful. In addition to that, I'm now fortunate enough to be part of the Provost Postdoctoral Fellowship, and in that regard, I get to really network with postdocs from across the community in very different disciplines. So this afternoon, I had a meeting with individuals from the schools, from the Department of Sociology, from education, from social work, and many of us are tackling disparities in different ways. But really, when we pool our resources and our energy and our thoughts together, I think this whole university, this community in Hartford has so much to offer us.
How delightful to see you the 21st year, sort of the living experience of the work that supports our young investigators. And you mentioned, I hear team science as a theme through both of your comments, and I think back to the prior panel. How have you navigated some of the potential barriers to team science, or how has that worked for you?
I think the biggest challenge has been explaining the unique perspective that nursing brings. And I think as a nurse, this role of the nurse researcher is so easily explained within these walls. But once you leave the College of Nursing, I have to be honest, there's still a little explaining that we all have to do about our perspective and the foundation from which on which we're educated, and what we bring to the table as nurses, clinicians, scientists, and thought leaders. So I think that's really been the challenge in working with the team, is explaining my unique perspective and what I can bring both as a clinician and a researcher to the table.
And I agree. I think one of the things that really happened for me during my pre-doc, and now in my postdoc I'm kind of embracing a little bit more, is as a nurse researcher, what can you bring? And I think that being part of teams, I started recognizing, well, this is the unique contribution that I bring. And I might know a little bit about what you know, and you know, somebody might bring that together in a way. And I think that in many ways, was part of the learning experience of really figuring out our role within research, particularly geriatric research. And I think both Tina and I have practiced clinically with older adults, so we bring that experience of having actually practiced with patients and seeing what they go through day in and day out. And you've worked in home care, I've worked in the hospital. So I think that in many ways has been really, and we've worked on studies where that's been really useful, actually. Yeah, all three of us have worked on studies where it was really useful, the fact that I, as a cardiovascular nurse working in critical care, could identify patients that would say to me, I don't have heart failure, and I could just look at their medications and look at their history and say, you do. And I think that unique role is something that in many ways you kind of learn as you work, and you figure it out because you're so used to being a clinician that now switching into research, you have to kind of be reminded of that in a way. But I think it's been particularly helpful to kind of recognize our own strengths, I think, moving forward.
And I'm thinking of that particular study. You are using your nursing background and the nursing lens not only to sift through the, oh no, I don't have heart failure, when that's what they're there for, but also how to elicit descriptions of symptoms in order to inform interventions. So that holistic approach, thinking about all the components of the patients or the research subjects, if you will. Again, harkening back to a question of the prior panel, healthcare is constantly changing. It's evolving, advancing, in part due to the great science that's going on by nurse researchers, some of the panelists here, and what I expect you all to be contributing to in the future. So, but there's a lot to do, and so you're at the very beginning of your careers. What do you think are the biggest population health issues and policy issues that you want to contribute to, that you'll make a stake on, or maybe you're already doing?
Yeah, I think, and we've kind of spoiled what our answers are going to be, I think, in a way, but it's really, for me, it's about social and behavioral determinants of health, and really thinking about how we can create environments and communities that actually promote healthy aging and promote people feeling included and actually feeling like the people in their community and the providers that they see actually care about their well-being in their healthcare. I think specifically thinking about so much of the psychosocial factors that we're both interested in is really thinking of ways that we can incorporate that in clinical care and clinical practice, but not only just in many ways. I remember being a nurse and completing these admission forms, and I would just complete them because it was part of the things I needed to complete. But really being thoughtful as clinicians about why am I asking this question and how does this question impact the healthcare that this person might receive now, has received in the past, the perceptions they have about healthcare providers. And I think that those things are really important. And recently, I guess 2 or 3 years ago, the National Academy of Medicine released a report of recommendations of social and behavioral determinants that should be included in electronic health records. And I was happy to see that they recommended screening for depression and screening for stress and actually screening for intimate partner violence. But I think in terms of thinking about identifying LGBT patients, which is one of the movements that's happening now in healthcare, people are still very reticent to ask people what they identify as. But in many ways, we could think about it, and this is one of the issues in my dissertation, which I've talked about, is that many of these national surveys don't even ask sexual orientation questions of older adults. And I think it just goes toward this, it's really like an ageist view in which we don't think of older adults as having a sexuality to them or thinking about sexual health as part of their general health. And I think that if we can actually incorporate some of those things into geriatric care, that we would have a much better idea of actually how to serve these emerging populations of older adults. Because really, we're both in the area of really minority aging, and thinking about how we can actually optimize the health of these groups, I think, is really important.
Perhaps it's a consequence of my wonderful mentors, but I feel that in many of the healthcare issues we face are really the consequence of ineffective policies. And what I've learned from my mentors is that those policies aren't always healthcare policies. So in my case, one of the goals, I think, Dr. Dixon, to your question, is that one of my goals is really to make our immigration policy and our social welfare policies more congruent with one another. And there's a lot of inconsistencies in policies across the country that affect individuals' health outcomes. So one of my focuses really, as I mentioned earlier in my dissertation, was this idea of individuals who come here and then have no access to affordable health insurance. And then we see a growing number of them coming to emergency departments with preventable complications of disease. So how can we advocate for them? And that's really one of the ultimate goals of my work, is advocacy, expanding and improving policies to be more congruent, to really help and serve some of these vulnerable populations, and helping them really experience better health, age successfully. Some of these terms like successful aging that we use to broadly apply to the aging population aren't really extending to minority vulnerable groups. And so that's part of certainly my work in sustaining their physical function and overall health. I would say the other big concern for me that I am hoping to be part of the solution for is finding more low-cost, community-based, sustainable long-term care solutions for these populations in particular. Culturally, a nursing home might not be everyone's answer to long-term care. They are expensive, and they are what people are mostly looking to avoid. And so much of my focus of late has been on adult day health services. And I'm currently working on a project where we take the adult day center where individuals typically go for 6 hours or so. Usually there's an RN on staff. They socialize with their friends. They get 2 hot meals. Their blood pressure is checked, perhaps. But we're really looking to expand that and use it as a model of care coordination. So in this case, on the project I'm working on now, the RN is following the individual to the ER, perhaps to their primary care doctor's office, to their home, and helping them with these care transitions to really make sure they understand their health out, what they're being told, to understand the medications they're on, the conditions that they have, and really improve outcomes. And we're seeing results of that already. 30-day hospital readmissions rates within this program are about 1.8%, which is very low, and emergency department visits are down about 25%. So there's a lot of promise. There's a lot of great solutions out there, and I'm really looking forward to being part of them.
Thank you. A couple of questions. This one I think goes to you, Tina. the writer notes that immigrant older adults are definitely a vulnerable group, and part of the problem, as you noted in your comments, was that many do not speak English, and I know in my own work they may bring a family member or a friend to help translate who really isn't the primary care provider. So this question is really a very practical one. What's the best way to solve the limitation? Do we hire or require bilingual professionals, use translators? What do you see as important, especially in the group you're working with?
Yeah, so it's really interesting in this adult day population. I was actually speaking with a nurse the other day who told me that she speaks neither of these languages, but she primarily works with a population in an adult day center where they speak Farsi and Russian. And she speaks neither of those. And yet she tells me that she has the best rapport with her patients. And so there's certainly bilingual staff. I think there's an obvious need for an interpreter. We have laws in place that make sure that every patient has fair access to those types of services. So I think certainly the communication is important. Family members are not the best translators. But what is really also important is being able to see that we can actually build a rapport beyond that. That language does not have to be this barrier between you and the patient. Yes, there's practical ways around translators, but you can still build rapport. And so anecdotally, I'm seeing that. And as I work towards the qualitative study that I'm going to be doing the rest of this semester, I'm really interested in looking at the strategies that individuals who feel that they've been successful in sort of garnering that, what they have used and employed in their settings. But I don't believe it has to be a barrier. And I think, especially from a nursing standpoint, we can really continue to build a rapport.
Two similar questions I'll pose to each, but first to you, Billy. And this is a question about your research. I think ongoing in your work with individuals now with trauma, and the wondering about how do you deal with providing social support to persons in your studies or in your population in the work that you're doing now who might need it, and what do you do when you come across someone who's experienced such trauma?
Yeah, I think that's interesting because I just had to think about this when I submitted a grant last week. I had to think about what we would do with these participants that reported. We're doing a study of trauma and post-traumatic stress disorder symptoms in Latino women and looking at cardiovascular disease risk in that population. And we kind of had to work through what happens if a participant becomes really upset or suddenly can't complete the rest of the study because they've become so overwhelmed by the types of questions we're asking them. And I think that one of the nice things about being at universities that are attached to medical centers is that, and being so close to the medical center both here and I'm doing the study at Columbia, is that there's like a seamless link between the services that are clinical services that are being provided and a lot of the research that's being conducted. And I think thinking about partnering with clinicians and clinical practices to ensure that participants are receiving that social support and that care, because we obviously can't do it in a short amount of time as researchers, that we have to collect data and do all these other things, but really ensuring that participants also know that it's okay if they can't complete the rest of the study. That's fine, I think, and creating an environment where it's open, so if they really want to actually discuss that with you, that you take some of the time to do that. And actually, Tina and I both worked as undergraduate students on Dr. Terry Fulmer's study of elder mistreatment over at Bellevue, and this happened sometimes with the patients that we were recruiting, where we were asking them questions, and then it was about elder mistreatment, what's happening to them right now, but then they would tell you about something that happened to them when they were 15, and they really wanted to talk about that, and we just kind of had to take the time to stop what we were doing and really listen to what they were discussing, and then refer them to appropriate clinical services. And I think that as clinicians, I think that we have some idea of how to do that, and I think that sometimes, especially a lot of the time when I've done some international work in Mexico, which I've had the opportunity to do through NYU, through both the niche program and the World Health Organization Collaborating Center here, is that a lot of the time we're working with nurses in Mexico, and a lot of the time they would get very upset about some of the questions we were asking them about abuse that they were witnessing in participants. And we kind of had to take the time to just let them be in that and just kind of explore that further. And I think that having that recognition that the study is important, but I think that making sure that these people are receiving adequate care and that their health, well-being is really the priority, I think, is more important to me.
And Tina, this question comes to you, I think, and that's thinking about immigrants living in their own ethnic communities, so those who may come to the United States and find themselves in a community. Do they experience health disparities?
Yeah, so I think that's such an important question. I thank whoever gave me that question. So this is something very important that we're seeing. The greatest misconception around these older immigrants is that once they are here, they're entirely cared for by their family members and by their communities, that they're just going to have, a full social network, their kids are going to be there for them. And that could not be further from the truth. In many qualitative studies, individuals describe being sidelined in their own household, and they experience this real role loss in their home and their community, which also contributes, I think, to their depression and social isolation over time, which is that in many, the majority of immigrants we're seeing are coming from are Asian and Hispanic immigrants, and many of those cultures and traditions, older adults are really respected individuals within the household. But then they get here, and they don't have a car, they can't drive, they have no money, they are constantly asking their adult children for stuff. They're asking their 8-year-old grandson to Google something. It's really, they lose their position as respected elders in the household, and I think that extends to the community overall. That being said, my point on that is that we shouldn't just assume that they're protected because they're in their household or their community. They are still extremely vulnerable, and that actually enhances their vulnerability. And then I would say also that I think I'll just leave it at that for now, but there's real opportunity there. Oh, I will add, that in California, there's one program that has been extremely successful where what they did was they had an ambassadors program. And so they took these South Asian seniors who were socially isolated, bound to the they couldn't drive, and people in the community who were not family members, not close friends of theirs, were ambassadors, and they would pick them up and they would take them to a doctor's appointment, or they would take them to fill out their Medicaid paperwork, or they would take them to fill out something, help them navigate bureaucracy, help them navigate the healthcare system. These individuals would receive training, and the older adults loved them because they would refer to them as like an extended kinship network, like this extended family that wasn't family, without the politics of family. They were just there to help and it was a very, very successful model. So I think communities can be there.
And I think you actually just got to the last question, and that's the role of social workers with your populations. And it sounds like the model that you're talking about in California might break down some of or expand the role and not think of it maybe in a siloed discipline.
Absolutely. And to give credit where it's due, the social work has been very forward-thinking in terms of this. Much of the research that I relied on in learning about this area has come from social work, and they've really been exploring this very deeply. So I cannot understate the role and the importance of social workers who understand the full context of these individuals' living situations. And I think where nursing steps in is now linking that to their health outcomes. And so that's where I feel that while much of the social work research has pointed out for a long time that there's these gaps in insurance coverage for this population, only now are individuals in nursing and other disciplines really linking that to health outcomes like cardiovascular disease.
Thank you both.
Thank you.
Well, that concludes. I'm sitting here thinking, well, this is our first. Maybe we can be an annual. I thought this was just really spectacular. I think to have heard from two people that are in the beginning, the dawn of their career, and two more senior researchers who have really got their battle wounds and scars in place, and to have two phenomenal moderators who have a rich background and history in their contribution to the science, to nursing science, to workforce science, to chronic disease. And chronic disease today, I mean, this is, it's like it's on everybody's tongue, is how are we going to prevent and manage chronic diseases, because we all know that's what drives the cost of our health care here in the United States and in other places. So let's have another big round of applause for our